Welcome. In this lecture, I will discuss nutritional assessment by indirect calorimetry. Actually, metabolic response and energy expenditure to critical illness are complex. Previously, they were giving a lot of nutrition, aggressive feeding for prevention of malnutrition and muscle loss. However, this showed significant harm, including hyperglycemia, hepatic steatosis, and mortality. In contrast, negative energy expenditure, when we give lesser than the needs of the patient, of course, it is associated with increased morbidity and mortality, hospital stay, infection, a failure of mechanical ventilation, weaning, and mortality. Actually, optimized energy supplies is impeded by lack of insight, actual vision, and detection of variable nutritional needs of the critically ill. Total energy expenditure includes resting energy expenditure, activity-related energy expenditure. The resting energy expenditure includes basal energy expenditure, which covers the physiological activities of the heart, of the brain, of the kidney, of the GI tract, and so on. However, when the patient is not fasted, we will include an additional part called diet-induced thermogenesis. This is a study published, and this figure was published in this journal, denotes that as a patient during critical illness, the needs of energy and nutrition increase and decrease and increase again and decrease and increase and so on, ups and down. So what is optimal? Actually, energy expenditure and the need for energy increase with overfeeding, exercise, agitation, the asynchrony with the machine, increased minute ventilation with hyperthermia, metabolic acidosis with some drugs like norepinephrine, caffeine, glucagon, cortisol. It increased with sepsis and inflammation and bear. In contrast, the energy expenditure decreased with decrease of the lean body mass in female gender, in the paralysis and comas, prolonged fasting and underfeeding, hypothermia, metabolic alkalosis with the use of sedatives, muscle relaxant, and beta blockers. And as you see that we have a lot of factors which increase energy expenditure and a lot of factors which decrease energy expenditure in the critically ill patient. So what is the better? How we can optimize the energy expenditure requirements? How can we optimize the nutritional support? This guideline included in the Journal of Critical Care 2020 and includes the energy and protein supplement in the acute energy phase, acute early phase, and acute late phase, and during recovery, in the well-nourished patient and malnourished patient. And as we see, there is a big difference between every category and with every time during the critical illness. So we are need for individualized real time. This is real time. We need real time nutrition. How much can we give? How optimal can we give nutrition for our critically ill patients? So ESPEN and ASPEN recommended that indirect calorimetry as a gold standard to measure caloric needs. It measures caloric needs now. Now, if you need to calculate the energy of the patient, energy needed by the patient in during this situation, we can use indirect calorimetry. Indirect calorimetry actually calculates the energy needs based upon the oxygen consumption and CO2 production per minute, and the values included in the an equation called Veer equation, or modified Veer equation, as you see. Indirect calorimetry can be included inside the circuit of mechanical ventilation. As you see, it resembles capnograph in mechanically ventilated patients, or can be included in spontaneously breathing patient under canopy hood to measure gas exchange at the same time. At the same time, it can be used in the clinic as a desktop calorimeter with a mask resembles the non-invasive ventilation mask. In the past, indirect calorimetry was complicated and was not accurate and consumes a lot of time. Now, the new indirect calorimetry uh, uh, attained high accuracy, rapid measurement, ease of use, easily to be disinfected between patient and the patient, reduced size and portable, and it has a battery so we can use it elsewhere when we have no power supply. So it is easy and portable and rapid response and has high accuracy. Tips and tricks when you are using indirect calorimetry. This requirements or this tips and tricks was published in Clinical Nutrition in 2021. I will discuss point by point. First, we have connections and filters, adapters. These parts are single use. The other parts are easily to be disinfected. So before you can use it, be sure that you use a new connections, a new filters and sampling line, disinfected machine. We are in need to use indirect calorimetry for about 5 or 10 minutes to attain a very steady gas exchange, so that the figure we obtained from indirect calorimetry in the form of energy expenditure reflects the reality, reflects the actual need of the patient. We are in need for 5 minutes or 10 minutes to attain this situation. Again, I'm talking about steady state of the patient. We have when you are proceed to calculate or measure, let us say it's measured and that energy expenditure, your patient must be in a steady state. Steady state means that the patient ideally not experienced mental or physical stress, be physically active or fed shortly, not be physically active, not be fed shortly before procedure. The patient must fast for about 5 hours before measuring indirect calorimeter. Also, if some patient has high grade fever, it's not suitable to measure energy expenditure in such a situation. And the same in the hypothermic patient. Hypothermia and hyperthermia affects the energy expenditure. Actually, this is not a steady state of the patient. For sure, if you have a patient of 40 degree Celsius and you calculate energy expenditure, you can attain, for example, 4,000 kilocalorie per day, which is not realistic, and we have to optimize our patients, correct the temperature to the normal figure, then we can measure energy expenditure in a right way. Regarding the patient on mechanical ventilation, change of the mood, of the mode of mechanical ventilation directly affecting the measured gas flow. So if you will measure energy expenditure, your patient must be on mechanical ventilation with a stable condition, and the mood was not changed in the last few hours. Also, if you give high fraction of inspired oxygen, the nitrogen will be very low. I mean, if you give, for example, Fi2 of 0.7, the nitrogen will be very low. This will affect the actual results of indirect calorimetry. So try to use it when you using Fi2 less than 0.6. Also, try to avoid endotracheal suction 20 minutes before and during measurements. Try not to change in the ventilator setting for about 60 to 120 minutes before measuring indirect calorimeter. Also, leaks in the, as you see, these graphs show leak. So any leak in the connection, as uncovered tracheostomy or deflated cuff of the endotracheal tube, patient who has tracheoesophageal fistula, subcutaneous emphysema, or pneumothorax, all these figures and all this situation affect the oxygen exchange and CO2 exchange, so we will attain unrealistic figures. Also, if you give high PEEP or unstable expiratory flow will retain some of the expired CO2, so this affects also the indirect calorimeter. High respiratory rate higher than 35 cycle per minute, this affects the indirect calorimeter. Also, when you are using canopy hood, you cannot add supplemental oxygen. Also, sometimes and some ventilators allow adding nitric oxide or helium. This affects the values which we can attain from indirect calorimeter, so we cannot use again indirect calorimeter with high FiO2, with supplemental O2, with supplemental nitric oxide or helium. Medication. Try not to change medication in the last 30 to 60 minutes, including sedatives, analgesics, muscle relaxants, vasopressors, beta blockers, analgesics. Patient who receives nutrition. If the patient receives bolus nutrition every 2 or 3 hours, try to make your patient fasted for at least 5 hours. On the other aspect, patient who receives continuous intra-nutrition through Ryle with a pump, this has minimal effect on indirect calorimeter and can use it safely, but try if the infusion rate is not altered in the last 1 hour before or during measurement, you can use it. Okay, so for continuous we can use, but not change the rate before or during measurements. For patient receiving bolus, try to make your patient fasted for 5 hours. Any agitation, seizures, fighting with machine, invasive procedure, shivering, unstable analgesia or sedation will increase the energy expenditure and give us erroneous figure. Avoid also any physiotherapy in the last 60. I recommend 60 minutes, not 20 minutes, but this is a recommendation. For patients who was on ECMO, some studies mentioned that calculation of energy expenditure could be over or underestimated during ECMO, and this is published in 2018. Then another publication in the same year give us another equation and use the pre-membrane oxygenation and post-membrane oxygenation, the same pre-membrane CO2 and post-membrane CO2, and include this figure in the VIR equation and attain some energy expenditure figure. And they mentioned that it combining used pre-membrane and post-membrane oxygenator blood gas can allow us to attain a reasonable figure of energy expenditure. Regarding continuous renal replacement therapy, it was controversial, and then it's mentioned in Clinical Nutrition 2020 that included 10 critically ill patients ventilated, treated with continuous venous hemofiltration, and found that this could not affect the figure of indirect calorimeter. Final words, I want to mention that indirect calorimetry extrapolates measurements obtained from short periods and therefore never fully accounts for the variation of energy expenditure during 24-hour, as we mentioned. It's just a snapshot. Indirect calorimeter should be either repeated every 2 to 3 days if feasible, and whenever patient clinical condition on treatment changes significantly, thereby possibly influence the energy expenditure. We can use every 2 to 3 days. However, if you have a major change in your patient, you can measure it again before the expected time. Optimization of energy provision is the mainstay of nutrition supply. So, indirect calorimeter is superior to all predictive equations and has become the clear gold standard in various settings for energy expenditure with a compact, affordable, user-friendly, and hence practical option. Thank you for your attention.